Good evening, dear colleagues and friends. Welcome to MIOM webinar meeting, the continuous education, one of the platforms that we are trying to do our best for continuing education in ophthalmology and bringing the new innovation, whatever is related to ophthalmology. Today we are very happy and proud to have our known figure and experts from different parts of the world. They are sharing their experience with us in the field of ophthalmology, especially in the retina. Um, we will have our speakers. I will just mention them according to alphabetical. Dr. Ahmed Salam, he's a professor of retina and uveitis, University of Arkansas for Medical Science, Arkansas, USA, and he is the president of 7th MIOM Conference and one of the executive committee board of MIOM Academy. Also, we are having my dear friends, Dr. Amr Farid. He's a veterinary surgeon, Maghrabi Eye Center, Dubai, UAE. Also, my dearest friend, Dr. Fahad Kuhail, consultant ophthalmologist at Moorfield Eye Hospital, Dubai, organizing committee of MIOM Academy and scientific committee of MIOM Academy. My dear friends, that we are all the time happy to be with us. George Rocca, he is a veterinary surgeon, perhaps vice president, and he is Elite Executive Board of MIOM Executive Board, Evers Executive Board, and he is Executive Committee of MIOM Academy. My dearest friend, Noor, I will read because we are apologize because you change your place of work. We don't know about that. She is a professor of ophthalmology, FEBO. She is a specialist in the retina vitreoretinal surgery, and she is working at private retina clinic and Unilis University, Istanbul, Evers Executive Board members, and she is also an executive member of Oculotromina MIOM Academy. We are happy also to have today with Dr. Sharat Hejd. He is a consultant and fellowship in vitreoretina at LV Prasad Eye, currently consultant retina in Prasad Netralaya, UDB Karnataka. Thank you for all of you, and also would like to thank Roche for sponsoring this meeting. The first half an hour we will do it with it will be with as a Roche symposium, and we are having two speakers, Dr. Amr and Dr. Fahad Kuhail. And we are happy to introduce first speaker, Dr. Amr Farid, and the floor for you. Thank you.
So good evening, everybody. I would like to thank Dr. Mohammed Al-Amri for his introduction and the whole MIOM team as well. And I would like to thank Roche for inviting me in this webinar. Today, we're going to speak about the power of the dual pathway inhibition of Vabysmo. I'm Dr. Amr, as Dr. Mohammed have mentioned before. I'm working in Maghrabi Hospital in Dubai. Anti-VEGF therapies has lowered the legal blindness, but still the retinal diseases remain a leading cause of vision loss. Frequent injections of anti-VEGF lead to high patient and caregiver burden and lower the adherence of the patients. Anti-VEGF therapies alone doesn't address the multifactorial nature of the retinal diseases. Can targeting the multifactorial nature of AMD and DME and RVO with the dual pathway can reach us to vascular stability and additional benefits or no? This is what we will try to see in the next slides. So there was, in the clinical trial, there was been more than 5,000 enrolled patients in different studies in the neovascular AMD and DME and the RVO. This led to improvement in the best-corrected visual acuity and reduction in the CST was maintained all over the studies. Across the 6 studies, the dual action of the anti-VEGF and the Ang2 inhibition improved the vision and drying and durability, and Vabysmo as well was tolerated in acceptable safety profile. As we know, all these are the Tenaya and Lucerne for AMD, and the Yosemite and Rhine for DME, and the Peloton and Comino for RVO. More than 5 million injections have been injected all over the world in more than, until October 2010, in more than 100 countries. Sorry, it is not moving. Just a second. Okay. Okay. There are many supporting studies that have been done in real world programs. More than 150,000 patients have been enrolled in 9 ongoing real world studies. As we can see here, the Voyager study, the Far Retina AMD, and the Far Retina DME, and others. And also there is more than 70 independent publications in enrolling more than 500 patients. Vabysmo reported favorable benefit risk in real world data readouts. Monitoring in the real world continues. So evidence for the role of the Ang2 VEGF-A dual pathway inhibition in the AMD and DME and RVO includes Ang2 is involved in the pathophysiology of multiple diseases. As we can see in the whole body, the Ang2 has been important or in the pathway of multiple diseases, as we can see in venous ulcers, in idiopathic pulmonary fibrosis, of course, in the retinal diseases as well, in cancer treatment, in the interstitial pneumonias, in wound healing, and in chronic kidney disease. So it seems that the Ang2 pathway is very important in the different multiple diseases. Ang2 and VEGF act as 2 distinct signaling pathways that drive vascular instability. So these 2 pathways leads to vascular instability. The VEGF acts only against the VEGF receptors, reducing the new vascularization and the leakage, while this pathway is still active. So we didn't treat the vascular instability, while dual pathway inhibition of the Ang2 and the VEGF-A may improve the vascular stability. This was a study which is called Ruby study that was done before. It was a comparison between aflibercept alone and aflibercept plus nesvicumab, which is an Ang2 inhibitor, and this is and with a low dose and another one with a high dose. So the idea between the Ang2 inhibitor was there long time ago, and we can see here, in spite of that, in this study, the visual acuity didn't improve between there was no statistical significance between the 3 arms, but there was statistical significance in the improvement in the CST. So Ang2, it seems to be more effective in the stability of the vessels, leading to decrease more in the CST. So the Vabysmo restores vascular stability through targeting both VEGF-A and Ang2. It is the first and the only bispecific antibody targeting 2 distinct pathways. So we aim for this dual mechanism to do disease control and extend the durability of the drug itself. So elevated VEGF was handled with the anti-VEGF, so leading to decrease the new vascularization and the vascular leakage, leading to reduction of the fluid of the OCT, and also resolution in the serous PEDs in the patients of AMD, and the resolution of the macular leakage plus resolution of the hard exudates. And the other pathway with the Ang2 have targeted the inflammation and the fibrosis, which was seen actually in the reduction of the HRF and the reduction of the epiretinal membranes. So dual pathway, Ang2 and VEGF, act in two distinct signaling pathways that drive vascular instability, giving us disease control. What about Vabysmo in real-world data? This is the in AMD, this is the TENAYA and the Lucerne, and this is the study. This was the first primary end, which is about 1 year, and the second one was 2 years. So as we can see here in the very beginning, in the 3 injections was matched between the Vabysmo and the aflibercept. We can see better improvement in the visual acuity in the 3 after the 3 loading dose injections, and it continues after until the end of the study in 2 years. Same thing happened in the treatment in naive patients, in patients with improvement in vision, as we can see along with the continuing of injection. These patients took 2 and 3 and 4 and 5 injections with improving in the visual acuity. And the same happened with the TENAYA and the Lucerne as well, with the CST reduction. And notice also the first 3 months with more the reduction of the CST more than the arm of the aflibercept. And same also this happened with the far retina AMD treatment. Naive patients have decreased the CST along with the treatment of the Vabysmo. What about DME? DME, it acts also the same in the Yosemite and Rhine, the same in the first 4 months of injections happened, and it continued along the end of the study with improvement of 10 or more letters with the 3 injections here in the second year versus 5 injections. And the same also happened with the treatment of the naive patients for the DME cases with improvement of the best-corrected visual acuity. As well, the CST acts the same, and there was in all the study there was decrease in the CST and almost a steady graph, as we can see here, was also 3 injections versus 5 injections in the second year, with also decrease in the CST along with the more injections of the faricimab. We can also notice here the high reduction of the drying effect of the after the CST after only 1 injection of the Vabysmo. So in summary, with 5 million vials of Vabysmo distributed all over 100 countries and extensive evaluation, this in the real world, rates of target events observed in the real world studies are within the rates observed in the clinical trials, and the far retina overall incidence of the IOI and the endophthalmitis are low and in line with previously reported Vabysmo. There is another study that I want to mention that's called the RONIX study, which is actually, it is an extension trial which assessed the long-term safety and the efficacy of the Vabysmo in treatment with DME. So these are the patients of pooled between Yosemite and Rhine, and they, until the 2 years, as we mentioned before, there were 3 arms. The first arm was for the aflibercept 2 milligrams, and then the patient. Can you please close? Yeah, there is an echo. Yes, thank you. So after initial dosing, there were the patients of the 2 milligram. After 5 initial dosing, there were continued on every 2 months. The second arm, after 6 dosing of Vabysmo, it was continued every also 2 months or Q8, and the third arm was 4 initial dosing, and it continued to 3 extent. So those first 2 have been changed to or switched to Vabysmo after the second year for the 3rd and the 4th year. And it contains here 2 years, as also here 2 years. So these were shifted to faricimab, either those on the aflibercept 2 milligram or in this arm of the Vabysmo. And let us see what happened, that these patients treated with the Vabysmo have rapid vision gains and improved CST maintained over 4 years. And those patients as well, which were shifted from the 2 milligram aflibercept arm, have gained more letters in the vision, as well as improvement in the CST, as we can see. From this graph, we can see here that the first absence of the DME was achieved faster in patients starting with Vabysmo rather than aflibercept. And after the 2 years, those patients who have shifted to Vabysmo have also success rate or increased to 99% at the end of the study. Vabysmo was well tolerated through 3 years and 4 years in the RONIX, with the nature of the adverse events consistent with the Yosemite and Rhine trials, with the most important thing that there is low rates of intraocular inflammation and no cases of retinal vasculitis or occlusive retinal vasculitis reported. So I'll go some cases, not too much because of the time, but these are my experience in the DME. This is the patient of 68 years old of age. She's a female. She's diabetic 20 years ago. She's non-proliferative diabetic retinopathy with DME. The problem was in both eyes, actually. She has a high HbA1c, and she had cataract surgery in both eyes recently since 2 years. So she was diagnosed maybe 1 year ago, to December 2023, and the best corrected visual acuity with 0.3 in both eyes. This is her right eye, the fundus photo for the right eye, and this is for the left eye. It's a non-proliferative. It seems good retina, not that much affected, but we can see here huge edema in the before the Vabysmo was given in the baseline on 26th of December. With as well, there is subretinal fluid, as we can see here, with a high CST of 652, which is actually improved a lot after the first injection only, indicating that the real world is matching what we can see in the clinical trials. And there was improvement in vision to 0.5, and almost half of the edema has been gone, and almost all the subretinal fluid has been gone. She came also 6 weeks after, not after 4 weeks. This is we can see in the retina in the real world. We continued injection, and you can see improvement in the third after the third image, and then a fourth image, and the visual acuity is improvement as well. So this is after 4 injections, and this is after 5th injections. And she came 2 months ago. In October, actually, her vision was 20/20 with a CST 215. So you can see the difference. She has 5 injections in the whole year, and you can see the difference between this image and this image at the end of almost 10 months, seeing the efficacy of the drug, of the Vabysmo. The left eye acts as well, nearly the same, a little bit different. We have here more subretinal fluid, more intraretinal fluid after the first injection, also the same, but the vision didn't improve here because of the presence still of the subretinal fluid, but the whole or most of the intraretinal fluid was resolved. Notice here that there was some epiretinal membrane, a fine epiretinal membrane, and this continued. We continued injection with the patient, and the patient really have, after 4 injections, started the subretinal fluid to decrease. And in the same visit on 6th of October, the patient, after 5th injections, she reached 0.8, and the subretinal fluid was decreased, and the CST decreased a lot. Patient improved as well, 2.8, and at this point, I continued to injection for her, give the 6th injection because there was still some edema there. So along of 6 injections, also the patient has improved from 0.3 to 0.8 with the reduction of the CST. In AMD, this is one of my recent patients, actually. She is an 84 years old. She's a female, diabetic as well since 10 years. She has a kidney disease, and she complained of decreased vision in the right eye. She has cataract surgery a long time ago, 10 years. Unfortunately, the left eye, she was having macular scarring from the same disease before, but she didn't do any treatment for the left eye. The visual acuity was counting finger in both eyes. She was coming to me and not very happy because she cannot read anymore, and she was really frustrated. And she was a nurse, old nurse as well, so she cannot read now. So she was really frustrated. We can see here the fundus photo. You can see here as well some subretinal hemorrhage and an active CNV there. Unfortunately, the left eye have been lost because of this macular scarring, as you can see, which it's not treatable, and the patient will not benefit from injections. So we started the treatment in the right eye, which is actually in August, very recent, and the vision was counting finger, as you can see here, very active and subretinal fluid. But with only one injection, patient improved a lot in vision actually, and she was very, very happy in the second visit after 1 month. And she was happy, although she was afraid from the beginning to take the injections, but she was very happy after the treatment, and she really was asking for the second injection, which was given actually 1 month after, and the patient improved as well for 0.2. And the third dose was given, and there was her last visit 3 days ago with the vision improved to 0.3 with no activity, and she was extended for 2 weeks or 3 weeks more because I didn't see any activity on this time. So summary, real-world outcomes for the treatment of the patient with AMD and DME differed from the clinical trials in the past. Now, real-world data supports Vabysmo clinical trial data, and the future with the Vabysmo that with the clinical trials have been reflected by long-term real trial data, and as well the well-drying effect of the Vabysmo showed greater CST reduction than compared to aflibercept and 8-AMG. And the durability as well of the Vabysmo improves anatomical and the visual outcomes, which allows patient to extend the treatment intervals. And I think my colleague, Dr. Fahd, will go through this durability in details. Thank you all for listening. And ready for questions.
Not at all. Thank you, Dr. Amr. If you can stop sharing your screen, please.
Yes, please. A second.
And then I will share mine. So again, thank you ever so much for taking us through some really beautiful data demonstrating the efficacy or the clinical efficacy of dual inhibition, particularly in the management of diabetic macular edema and neovascular AMD. And I have to say, I really enjoyed your cases. I thought those patients did remarkably well with Vabysmo. For those of you who don't know me, my name is Fahad Kuhil. I'm a consultant ophthalmologist at Morpheus Eye Hospital, Dubai, but I was previously a consultant in the United Kingdom. I'm also a clinical professor at Mohammed bin Rashid University of Medicine here in Dubai. So there is a difference in Vabysmo in patients with wet AMD. So as Dr. Farid said, Vabysmo was validated by 2 robust phase 3 trials in treatment-naive patients with neovascular AMD. And disease activity was based on either central subfield thickness or best corrected vision or clinical exam. So if you saw disease activity either in the OCT or there was vision impairment, or you examined the patient, you identified macular hemorrhage, you could trigger a treatment for the patient, which then determined whether they had 8-week interval, Q12 interval, or Q16 interval. And you reduced the treatment interval, again, based on disease activity either in the OCT, vision impairment, or the presence of macular hemorrhage. But to extend the treatment interval, you really had to have good stability in terms of disease activity, stable vision, and no evidence of macular hemorrhage on the by microscopy. So to reduce the treatment interval, it was very flexible and you could treat the patient much more easily. But to extend, you had to meet quite a lot of criteria to extend. And then you maintain them if either the extension or reduction criteria were not met. And so basically, Vabysmo treat and extend dosing reflects real-world practice. When we decide to reduce the dose interval, it's driven by changes in OCT and does not require the vision to decline. Whilst if you compare that with, say, other drugs, for example, 8 milligram Eylea, if you look at those trials, you had to have an OCT change with a corresponding vision change. So there was a vision and decline in vision. But in the Vabysmo trials, it could be either, which meant that patient could be treated more readily, which reflects the real world practice. And with this kind of flexible disease treatment, we got stable vision and CST, particularly when we dose patients at Q16 intervals over 2 years. So this is looking at the vision and looking at the CST, and you're comparing Vabysmo overall, which is the blue line, with Vabysmo always on more than Q12, which is the purple line, or Vabysmo always on Q16, which is the blue line. And as you can see, the vision gains were very similar and the CST gains were very similar. So Vabysmo delivered extended durability with 80% of patients on more than Q12 week treatment intervals at year 2, with 80% of patients achieving more than Q12 dosing, particularly in year 2, with almost 63% at Q16. 56% of Vabysmo treated patients met the criteria for potential Q20 if this was allowed in Tenaya and Lucerne. So when Tenaya and Lucerne were designed, the limit was only to Q16. But if Q20 was allowed, 44% of patients in year 2 would have met the criteria for Q20 week extension, which is interesting. So just to reiterate, particularly in neovascular AMD trials, if there was no BCVA loss and no CST increase and no new macular hemorrhage, dosing was extended by up to 4 weeks. If there was BCVA loss, either 5-letter loss or 10-letter loss, or a CST increase, or a new macular hemorrhage, the dosing was reduced by either 4 or 8 weeks. And if the extension or reduction criteria were not met, dosing was maintained. And it's really important to understand this because the definition or how you define active disease in a clinical trial can actually impact this durability. So as I said to you, in Tenaya Lucerne, it could be vision or anatomy that dictated whether the patient had another treatment. And so with that, 78% of patients were able to achieve a durability of Q12 weeks. And this matches how we treat patients in the real world. We take the OCT into account, we take the vision into account, but also if we see hemorrhage at the macula, we tend to treat. But say we applied the hypothetical disease activity criteria. Say we said you had to have vision and an anatomical change to trigger a treatment decision. So you had to have a vision loss of more than 5 letters, and there had to be a CST increase of more than 25 microns, or a new macular hemorrhage, then actually 96% of patients in Tenaya Lucerne would have met Q12. So it's interesting, just by whether it's or and, you can change your durability from 78% to 96%. So it's important as retina specialists that we realized some of the durability benefits that we're seeing. Can somebody turn the microphone off, please? So it's important to understand that some of the durability that we're seeing in some of the trials isn't necessarily to the drug itself, but actually how you've defined active disease and whether you've said or whether you've defined as and. So as I said, the definition of active disease in clinical trials impacts durability. So in Vabysmo, it could be vision or anatomy. And with that, 78% of patients managed Q12 weeks. But if you made a hypothetical disease activity criteria where they have to have vision with anatomical criteria, as in they had to have a vision drop with a CST change, the number of patients who could become Q12 increases to 96% at week 20. If you compare that with aflibercept 8 milligram in the Candela trial, which was the phase 2, which had very similar disease activity assessments as in Tenaya and Lucerne, which was vision or anatomy, 53% of patients met the Q12 week, were able to be treated at Q12 week intervals at week 44. If you compare that with Pulsar, where now you have to have a vision change and an anatomy change, your Q12 interval increases to 83%. And you have to ask yourself, is that increase in durability due to the drug or how you define disease activity? So it's important that the application of vision and anatomical criteria can increase the assignment for longer dosing intervals, and these may not necessarily be criteria that reflect real-world practice. So let's look at some hypothetical cases. So you have a neovascular AMD patient, comes in 12 weeks after completion of the loading dose. The parameters are the vision has reduced by 1 letter and the CST is increased by plus 75 microns. Would you treat or would you observe the patient and reassess the patient a month later? I personally would treat because of the CST increase. And actually in TENAI and Lucerne, you would have treated the patient. But in PULSAR, you would not have treated and you would reassess the patient in a month's time. What about another scenario? A patient comes to you 12 weeks after completion of the loading phase. Their best corrected vision is -5 letters with a plus 80 micron increase in central subfield thickness. Would you treat the patient? I personally would treat based on the anatomical criteria. And again, in TENAI or Lucerne, you would have treated the patient, but in PULSAR, the treatment would have been withheld, and you would reassess the patient a month later. What about you have a neovascular AMD come in 12 weeks after completion of the loading phase? The vision is stable, the CST is stable, but you've now identified a new large macular hemorrhage. Would you treat or would you observe? I personally would treat, but again, in TENAI and Lucerne, you would have treated, but in PULSAR, you wouldn't have treated. And what about a patient with a best corrected vision loss minus 11 letters with a CST increase of plus 80? Would you observe? Would you treat? I think most of us would treat with a vision drop and a CST increase. And again, in TENAI, Lucerne, and PULSAR, you would have treated the patient. And finally, if you have a neovascular AMD patient, comes in 12 weeks after completion, the vision is plus 1 letter gain, TST is stable. Would you treat? Would you observe? I think most of us would observe. And again, in all trials, you would have observed. So it's really important when you have any new drug that you make sure that the clinical trial results are matched in the real world. So you can definitely be reassured that the clinical trial results seen tonight in Lucerne are seen in the real world. So in weeks 124 and 24 to 48, you had 4.6 and 3 injections. And in far retina neovascular AMD, which is a US trial, and far wide neovascular AMD, which is a UK trial, looking at treatment naive patients, in months 1 to 6, you had 4 injections, and in months 7 to 12, 2.4, and the same in the UK trial. And that's just reassuring to see that the extended durability that we saw in the clinical trial is actually seen in the real world. So that increases your confidence that the drug will deliver for your patients. And what about the proportion of patients who get greater than Q8-week intervals? So again, in TENAI Lucerne at year 1, 78% of your patients were on more than 8-week intervals, which again was matched in the real world, with a Morpheus UK study showing 71% of patients at year 1, and a Japanese trial showing the same in a completely different population. A very interesting trial from Liverpool, again in the United Kingdom, which was a one-stop clinic where patients were either reviewed face-to-face or virtually. They had a vision, OCT, and an injection, and they've been using Vabysmo since September 2022. And the patient would get 4 loading doses and treat and extend when dry. And they treated about 1,800 eyes with 11,000 injections, with a third of the patients treatment naive. And again, reassuringly, at week 52, 49% of the patients were Q8 week to Q11 weeks, with 39% of patients at Q12 week to Q16 weeks, with more than 40% of patients on more than Q12 week intervals. And again, at week 80, that increases to 66% in neovascular AMD, which is very reassuring, with excellent gains in mean change in vision. So Vabysmo's durability in the real world matches the phase 3 clinical trials. So we see the durability in the trial, but we also see that durability in the real world. So we can be confident that using Vabysmo will give us durability for our patients and improve the capacity issues and reduce the treatment burden. What about diabetic macular edema? So again, in Yosemite and Rhine, you had Q8-week dosing in aflibercept and then Vabysmo arm, and then you had a third Vabysmo arm that had treat and extend. And then in Ronex at the year 2, both the aflibercept and the Vabysmo Q8-week arm were switched to Vabysmo treat and extend. And again, in Ronex, what you were seeing in the Vabysmo treat and extend, that Q12 and Q16 was seen in 78% of patients. And in those patients with prior aflibercept, 77% achieved Q12 week and Q16 week in diabetic macular edema at year 4. Also, if I can show you the similar trials that were done in the UK and the US, far retina in DME and far wide in DME, again, you're seeing in the second half of the year that reduced number of injections, matching what we saw in Yosemite and Rhine, which is a clinical trial for Vabysmo. So fewer injections were seen during the second 6 months of Vabysmo, indicating extension of the treatment intervals and durability because of the dual inhibitory effect of blocking both anti-VEGF and anti-Ang2. So I've got another couple of minutes, so I'm going to try and stick to 15 minutes and not go over too much. So I'm just going to show you one AMD case and one diabetic macular edema case. So this is a 70-year-old gentleman. Yes, sir.
1 minute, please.
Okay, no problem. It's okay. Dr. Fried took too much of my time. That's fine. I will try and do these cases quickly. 70-year-old gentleman treated with Vabysmo in the right eye for wet AMD. He was treated. It was a treatment switch from Eylea. During follow-up, he developed early neovascular AMD in the left eye. So I commenced him with Vabysmo in the left eye, and vision and anatomy stabilized on 3 to 4 monthly Vabysmo injections following loading dose. So this is his OCT. So again, really good anatomical reductions. With after the loading dose, I was able to extend the treatment intervals to every Q12 weeks on Vabysmo, but he was an early treatment-naive neovascular AMD, and then very quickly on diabetic macular edema. 74-year-old gentleman, Emirati descent. He's already got poor vision in the right eye, reduced vision in the left eye. He's already had Eylea and the other hospital. He's fatigued with the burden of injections. His vision is 0.62 in the right eye. I diagnosed him with center-involving diabetic macular edema in the right eye. So I give him Vabysmo. This was his vision. After one Vabysmo, a rapid reduction in central subfield thickness with vision gain. I give him 3 monthly doses. And then basically I was able to extend him to every 12 to 16 weeks, but I kept treating him on a treat and extend basis every Q12, Q16 week, maintain the current level of vision and maintaining the anatomical reductions. And I will stop there and thank you for your attention.
Thank you very much, Dr. Fahad, for this presentation. Also, Dr. Amr Farid. We are having only 1 minute remaining. If there is any question or comment from any of our panel here. Any questions? Any comment? Dr. Ahmad, Dr. George, Noor, anyone you want to have? Dr. Sharat. So, okay, how it's Dr. Fahad and Dr. Amr, how do you feel that, what is the addition things that we can get a result from having Vabysmo? What is the difference now? Is it only actually a durability or it is also efficacy? Yes, Dr. Fahad.
I think both. I think definitely the durability. You've seen from far wide in the UK, both DME and AMD, same with far retina from the US, that in the second year you're reducing the treatment intervals. But for me, particularly when I've had an insufficient response to an anti-VEGF agent, and I'm not keen to switch them to a steroid, I want to switch them to an alternate anti-VEGF, I won't necessarily give them a higher molar dose. I will switch them to Vabysmo to try and exploit the dual inhibition effect Because what I found in those cases, and we just run out of time because I had a case in amongst my presentation where this patient had received 3 to 4 Eylea with no vision improvement, no CST improvement. But when we switched him to Vabysmo, we started getting the anatomical reductions, and I was able to start to extend the durability. So yes, it's been helpful, particularly when I want to switch anti-VEGF. I see it as a different class. It's added. It's giving me something added, and that's just not an anecdotal opinion. When you look at the head-to-head phase of the Yosemite, in Sinai Lucerne or in Yosemite Rhine, the anatomical reductions are better when you're comparing monthly Eylea, 2 milligram, to monthly Vabysmo. But also they did a fluorescein angiography study where they looked at baseline fluorescein angiography leakage and compared what would happen after a loading dose of Eylea with a loading dose of Vabysmo. And what you find is that there's a marked reduction in the fluorescein angiographic leakage with the Vabysmo that is not seen with 2 milligram Eylea. But Roche knew this when they were when they wanted to put this drug forward for study, because they knew this from animal studies.
Thank you.
When you inhibit angiotensin and anti-VEGF, you do reduce leakage markedly.
Okay. Dr. Amr, you want to say anything? Dr. Fahad, he will not stop. If you keep him, he will continue until tomorrow.
I will just, I really agree with Dr. Fahad. There are some patients that when you shift them, if they are not responding to Eylea, you can shift them really to faricimab, and they might respond. There is a rule for the Ang2, and I agree with that. For the fluorescein angiography study, this is a very important study that gives us an idea about the vascular stability that probably came from the Ang2. I will stop here for you.
Shukran. Thank you very much, Dr. Fahad, and thank you both. I think it was an informative. So now we will move to the second part of this webinar meeting, and we will start with Dr. Ahmed Salam. He will start his presentation and for discussion. Dr. Ahmed, you are with us.
Thank you so much, Dr. Amri. Thank you. Can you hear me?
Yeah, we can hear you very well. Yes, please.
Thank you so much, Dr. Amri, for the kind invitation. Great to see friends, and you all look great. Thank you so much. A question: how many minutes do I have?
2.5 minutes.
Okay, you gave Fahd more. I know you like Fahd because he's next door as well.
You have a time, whatever you want. So we
no,
open.
I'm just. No, how much time is scheduled? Just to know if I show one
10
case.
minutes. 10 minutes. Yeah,
10 minutes.
We can have 5-minute presentation, 5-minute discussion, like this, whatever. I don't know.
5
is
minutes?
it a case?
Okay, all right. Okay, lovely. So I just want to, okay, if it's 5 minutes, I'll show you a case, and I think maybe we can have a discussion. It's surgical, and let me just run it here. Okay, all right, fantastic. Okay, let me just run it from here. Because the posterior hyaloid is multi-layered. Sorry, let me, actually I can, it's narrated, but let me just, sorry. We moved on to using the. I apologize. Give me 1 second. I'll run it from another source because then I can put the voice down. So this is a patient who had dropped nucleus, and this patient actually is very interesting. It's about 80-year-old patient, and I was operating this patient as a part of a visit to King Khalid Eye Hospital in Saudi Arabia, and I did not expect that this patient would have such adherent hyaloid. So the story is, and I was doing live surgery with them. The story is a dropped nucleus patient, and the plan was to do vitrectomy and put a lens in the sulcus and remove the lens. So this is here what I want to show you. Let me just put the voice down. Can you see my video?
Yes, we can see.
Okay, fantastic. So here is the drop nucleus, and again, not expecting that this patient would have adherent hyaloid, but the hyaloid is so adherent, as you can see here, trying with the cutter, and then trying again with the cutter, and then it's not working. And I think just to want to highlight something, this is a beautiful drawing that one of my previous fellow did for me. And it shows the reality of the posterior hyaloid here in green, which is not one layer, it's multi-layered. And sometimes when it's so adherent, what happens when you try to get it with the cutter is this, and this is here just a histology section showing it's multi-layered, is this actually, when it's very adherent. And especially that nowadays we're using 23 and 25 and 27, so the suction power, because of the sphere of influence, is not as big as the 20 gauge. So you may be just getting this. So my question, again, if we can have 10 minutes, so we'll put the discussion in it. My question to the
No, you
panel.
have all the time, Dr. Ahmed. We are just, please go
Sure,
ahead.
sure. No, my question is to the panel, is what would you do next if you cannot get the hyaloid with the cutter?
Okay, we can hear from all. We
Yeah, that
start
would
with
be
Abba.
great.
Who's willing to start? Okay, Amr
Yes. Yeah.
or Noor, sorry, any one of you.
Go on, run with that.
Amr, please go ahead already.
So first of all, I will, the same as you did, we will just try to see this. We'll just put some triamcinolone to try to identify it. I'll go for the high magnification more. I'll try first with the forceps. If it didn't work, I'll try for the pick, or we do like the capsulorhexis. We go just very near to try to make a hole in this posterior attached posterior vitreous, and then through the hole you can go under the posterior vitreous and do the PVD, initiate the PVD.
Fantastic. So
Noor,
forceps, pick.
there is another suggestion, Dr. Ahmed. You want to listen to another suggestion?
No, yeah, please, all the panel. So Noor,
Yes.
please go ahead.
Noor or George, whatever. We are hearing you, Noor.
Thank you. I think you have really mentioned well my colleagues, but sometimes also you can reach, for example, there was a slight schisis in the, not sometimes from the disc, but also you may start as time passes. For example, sometimes I wait, I reduce the volume of the vitreous in the central area, so the hyaloid attachments meanwhile get loose. For example, this part, for example, and then you sometimes it is nice to find the place detached from the mid periphery, and then you go back, and with those liquids all washing in between those times, sometimes you can lift from the disc also, apart from using a pick, a forceps, and everything. But sometimes, very rarely, also inflamed eyes, especially. That I had one case, for example, 1 week ago. It was the most difficult patient, and I could only peel the ILM or something like in the macular area, and then try to find the layer and then lift all the hyaloid. But it was really difficult one, extraordinary one. Thank you.
Okay, excellent. And Dr. And George? How are
Hi.
you doing, George?
Good to see you, my friend. Very nice case and very nice drawing. Sometimes it's pretty much hard. It's unusual for a man with 80. It's more common if you have a patient with less than 50 years. But I used not only the cutter, but we can use the flex tip and we call the fish maneuver, and the flex loop can grab not only in the optic nerve, but you can go for the vessels that sometimes we can get some vitreous and try, but many times that's so hard. I used to peel with forceps. That's I think it's the end of the maneuver that you have to use to lift a very tight posterior hyaloid. But very nice.
Excellent. Thank you so much. Okay, any...
There is Dr. Sahar.
Sometimes I use the extrusion cannula with the 650 vacuum, where the 25 gauge extrusion cannula will put extreme volume just nasal to the disc. Also, we can try to lift the vitreous.
Lovely. Okay. I'll switch to something else related. I think because this one, I'll show you what happened with this one. So this is the technique of the pick here. And I hope you can see my screen, right?
Yeah. Okay.
Okay, so this is a technique. It's actually very similar case and was a drop nucleus and was around 80 as well, but was a female. And this is from Arkansas, not from Saudi Arabia. So it's interesting. I think just be wary that drop nuclei cases may not have PVD for some interesting reason. So this is a case here, same thing. Gwen, we try the cutter, and we're not getting anywhere.
Dr.
And the
Ahmad, we are
needle,
seeing only, I mean, there is no video. We are seeing only.
there's no video. Okay, all right.
Okay, now, yeah.
Let me do
Okay.
something now. So I do apologize. We'll do the screen. Okay, can you see now?
Yes.
Okay.
Now the draw. Okay.
Now the draw. Now. Okay, can you see it now?
Okay. Yes. Yes.
Okay, so it's very interesting. It's another patient and the same problem. And you can see here with the intraoperative OCT, the layers of the vitreous. And that's really, it's just we're not getting the outermost layer. It's just we're in the innermost layers. And here and then this is where the pick comes in. And I think the pick is very useful, as Dr. Amr and Noor have mentioned, is it's a needle, it's a bent needle, and it's allowing you to try to get the outermost layer. Here we're still in the inner layers, but you want to try to get really deep and get the outermost layer, make a nick in it, as you can see in the picture, then you're up and running. And that's usually my next tool when this happens, is I go to the pick. And then you can see here, we're now in business. And then the next would be the going to the cutter now. So now we're here, and now you go with the cutter and it works. Okay, so that's usually my next step to go to. So what happened in this case is back to the case we were discussing. So here, and I went to the pick because that's usually my next one, but I really could not get to the outermost layer. And again, I thought here I got to the outer layer and I was trying again with the cutter, but I was still just lost in the inner layers. I really did not get to the outer layer. And then usually my next step here is to do an ILM peel, is to stain and start an ILM peel, as Dr. mentioned. And this is usually my next step. But then, and this is really the beauty of like talking with people and operating elsewhere and discussion, is because Dr. Ramsey there from KCash, and he mentioned that he uses the diamond duster. And I thought actually that's a clever move. Let's try the diamond duster, which I really usually don't use. Or I even don't use the not the forceps, the flexi loop for that. I never used it. I just go like ILM peel after that. But here, this is the diamond duster. And I think the idea of it is that you're able to graze over the retina and scratch the outermost layer as you move the vitreous. And once you have a scratch in the outermost layer of the hyaloid, then you're into the business. Then you can go underneath. And I think this is here what's working. So I think, what I've learned is, okay, well, the next instrument can be the flexi loop or the diamond duster. And then after that, I would stain with blue dye and start the ILM peel. I don't need to complete, start the ILM peel, then I get the hyaloid. But I think my message as well from these cases is, if you really try, and you cannot get it, and you've tried everything, I would just leave the hyaloid. Don't really like complicate things. I would just leave the hyaloid and try to remove the vitreous, get the vitreous away from the nucleus, and just remove the nucleus and just finish. I mean, you tried. I wouldn't like keep on challenging nature. You cannot get the hyaloid. That's not the end of the world. And in many times, nothing is going to happen. But I would not like create problems and go into problems because I have to remove the hyaloid. Well, you tried, it's just not working. I would just move on. I think that's also like my point from this. And yeah, thank you so much. I finished. If we have time for discussion or more questions, would be fantastic.
Is there any comment or question to Dr. Ahmed? Yeah. Yes, Dr. Amr.
Just a small comment, as Dr. Ahmed, as you said, that there are layers of the vitreous attached to the optic nerve. So what you have done with the PIC, that you remove a part of these layers, and now it is clear from the triamcinolone. So another idea that to put triamcinolone again, and it will stain the rest of the vitreous, attach it to the retina. Then you're in the same place, in the same point, you will find still there is some vitreous. You try to open it again with the pick, and this time hopefully it will come with the remaining layers attached to the retina, and you continue the
Yeah, that's a great point. That's actually a fantastic point. Yes, you're right. Maybe I removed the hyaloid, and that's why I'm not seeing the remaining outermost layer. Yeah, that's a great point.
Noor?
Thank you. Thank you, Ahmed. Great discussion and nice case. Sometimes you're right, it's very difficult, but what I do also with more concentrated triamcinolone, just small droplets around optic disc and contact macular lens. Because the peak is sharp, I don't feel myself as you cannot understand how deep to go. Sometimes it can cause bleeding also. So it helps the visualization a bit more, but thank you again for this nice
Yeah,
case.
yeah, no, this is actually a macular lens, but this is with 3D. So with 3D, it's a bit different from the microscope. You can actually see very well with the green macular lens, as if you're operating with a microscope with a contact lens. If you put the contact lens with the 3D, you get like an amazing view. You'll be like even times 100. But I peel the ILM with this lens with the 3D, but with the microscope, I cannot peel with this lens. I would put a stick-on macular lens. But no, you're right. Actually, it's a good point. You will see even like better and better and better. But that's the high magnification lens.
Pediatric cases, sometimes it is so. So I feel myself more confident to see better depth of focus.
Yeah, no, but yeah, no. If I'm using the microscope, I cannot peel with these lens with the green lens, but with the 3D, it gives you a very good view. Thank you so much.
Any other comment from another colleague, or we will move to Dr. George? I think there is, I don't know, questions. One question is coming there. How much is the, oh, sorry, this is something below, for the before. Okay. Okay, we can move to Dr. George now. Please, Dr. George.
Yeah. Let me share. Everybody can see?
Yeah, we can see.
Wow, good. Thanks so much to invite me for this nice discussion and webinar. My disclosure, and I'd like to say that I'm very exciting for the next MIO 2025, gonna be October 31st to November 2nd, the year of artificial intelligence. And now I have a very, very exciting case for me. It was a 52 years old female with diabetic, and she had lost the only eye vision 10 days before. And she had a PPV for diabetic macular traction 2 months ago. And now she has only count fingers 1 meter. And this is the eye that I saw. At the first time, I said, wow, I can't do anything for her. And I spent something like 2 or 3 nights thinking about what we can do with such a case. I have a huge macular hole, many holes, traction everywhere, and what to do. And I said, I can try, but it's not guaranteed that I'm gonna have any good result. And then this is the macular hole has more than 3,000 microns. And what to do? I start to peel everywhere.
Can we stop here, Dr. George? Can we stop here?
Yeah.
Okay, we can have the opinion of all our colleagues what they will do. Dr. Salam, Amr, Noor, Sharat. So, any one of you, if you are now in the position of Doctor, are you going to do or not? First of all,
I would refer the case to George. Center Brazil.
This guy is my friend for sure.
Okay, yeah, Center Brazil, exactly. No, I think this is a very tough case, and I think what George mentioned is so important. First, you have to highlight the difficulty so that you and the patient are on the same page. I think this is very important. And second, I think this is difficult. Also, I would under promise because it's a very difficult case. Lots of things. Diabetic delamination is very challenging, let alone this big macular hole. Third, I think it's worth having a go. I think, you know, the patient, for many reasons, even just keeping an eye and as an eye, if we get any peripheral vision is a bonus. If you get any bit of central vision is a bonus. Third, I would start as if I'm doing a diabetic delamination. I like to start from the disc and go forward. I'll give anti-VEGF before. I'll start the dissection, and I'll try to clear the macular area. And I wouldn't worry much if I cannot clear the periphery, but my main aim is try not to get holes as much as I can, other than the macular hole. And then after that, I will drain from the disc several times from the hole several times under PFCL. And probably try to do an ILM flap and cover it, or use an autologous ILM, or maybe amniotic membrane. Depends how much smaller size I can get it, and I'll end up with gas, long-acting gas. That's what, you know, this is like the ideal plan, with me sitting here, feet up, and then seeing what Dr. Rocha is gonna tell us. So this is like my take here.
Imagination. Okay, any other different opinion?
Yeah, I would have
Bharat, yes.
added buckle to this. I would have put an ensacclage or a buckle to support the peripheral breaks which are there, because she's one-eyed also. I will add a buckle to that, and I will do extensive peeling of the ILM. And I may not put any graft like retina graft, or I may not plan for any amniotic membrane graft, because if you put the visual acuity may not improve. I may do a slight adjust laser I may add with silicone oil. I'll be thinking for her, because she's literally one-eyed.
Dr. Noor or Dr. Amr, anything to add?
I think they have mentioned very nicely. The hole can decrease as we peel most. Flap can maybe close, but if not, amniotic membrane, I would prefer actually to cover, not the deep inside, but to cover with the attaching sticky side, the proper side. Buckle can be a good idea, or else it can go to with retinectomy, which we don't like. And if it ends with retinectomy, we can use mitomycin C, as my colleague from Turkey has been using it, like in these tough cases, protecting the macular area, but only for the periphery. I think silicone oil would be my preference. I'm not afraid of silicone oil, but I use 5,000 centistoke. It depends. I mean, it depends on the end of the case, if it will bleed or not, how many holes will be there or not, or something. Thank you.
Amr, anything?
Yeah, it's almost the same as my colleagues have mentioned. I will. It depends at the end of the case how it will appear. The hole, it will be a little bit smaller than we are seeing right now. But the two things, first of all, counseling with the patient. This is very, very important before the surgery, because we're not expecting too much. And then to be ready for everything, you have to have your amniotic membrane with you. You have to be in mind that you will do retinal tissue, or to put retinal tissue or retinal flap. Yeah, you have to have your ideas according to the case, how it will go. Let us see what Dr. George has.
Okay, let us see George.
Yes.
And then before finish the video, just make some comments. And these holes come from the traction from the medial, periphery, and periphery. In the macular area doesn't have any hyaloid, but in the middle and periphery, we can get a lot of membranes and traction. And in the nasal area, we have a huge break. And I decided to peel very meticulously. And when I finished to peel, I didn't have any amniotic membrane. I decided to make a big patch of retina and do autologous transplant. I get this retina from the nasal area, and I show a little bit what I did. Go ahead. And then I peel, sometimes have some bleeding, and something that's happened. But I can control if I pressure. I use very little counter. And then when I finish, I just say, I have to punch this hole. I measure, and I get this big piece of retina, and I move to the hole. I stop the infusion, and I clean with and make the fluid gas exchange very slowly. Took something like 20 minutes, very low vacuum to not to dislodge the retina transplant. And then I put oil, 5,000 cent stoke, and make a lot of laser for this patient. And then this right the end, the way of the retina pads. And this patient I'm following for more than a year. And after 1 month, she got something like 20/80. And after 1 year, she got 27. I still keeping the oil just because the optic nerve is very ischemic. I'm really afraid to take this oil, and the vision drops. But was what I did. And thank you. Just open for discussion. That's me.
Thank you very much, Dr. George. Excellent. Okay, any comments after that? Ahmed, Amr, yes, please, Amr.
Yeah, it's amazing that the patient has vision. Yeah, really happy for the patient, and very nice case. And good that you go with the autologous transplant. And I don't think that you need to remove the oil. She's one-eyed. Just keep the oil. The patient will be
Yeah,
good.
that's
I
the
would say
idea.
as well that if you might remove the oil, that the patient might lose vision, or even a little bit will be less. So you use the glasses, and that's it. Follow up. We have patients, of course, all of us was 15 years or 20 years with oil and no change. So just keep it for.
And
Ahmed?
Yes, George, very nice, and thank you. So I'm happy for the patient. I will send my next case to you. Yes, if she can fly to Brazil. But it is wise. I mean, if you have a retinectomy area, just to use it for the macular wall, of course, it's also for the vision. A very nice ending. So I wouldn't leave. I wouldn't be careful. I mean, so concerned about the silicone oil in the eye. Sometimes we may leave it as long as there is no complication, and sometimes we can change it even in years. So thank you for sharing this case.
Yeah, George, I think it's a very great case and really a fantastic outcome. Usually when I use oil in diabetics, I don't remove it because it's like a very last resort when I think of oil, and I think my removal rate is very little because the eyes I put oil in, it's in a way I'm just like, this is not, I'm gonna not remove it. So I think it's a fantastic outcome. I'm very surprised we got up to 20/70. But this is an amazing outcome. Fantastic. Again, as Noor saying, we know where to send our cases now.
Okay, is there any other comments, or we can move
Yeah, I
to?
have some comments about this. And one thing is, I agree completely. I don't like to use oil for diabetic, but when I use this oil, is the last source of resource that I have, and like this case, I keep this oil almost forever, and I try not to remove because can drop the vision. Another thing is about autologous transplant. In my experience, I have something like in a diabetic macular hole, 5 or 6 case, and didn't really improve that much. But I have 3 cases that's a secondary macular hole after retina detachment. And this case, I think they got much better. In this special case, I think because we have a big retina detachment in the macular area. When we got the macula flat and the hole is closed, I think the patient can use the reminiscent area of the retina. And the theory is when we use autologous transplant from outside area, we can get very fresh Miller cells. These Miller cells can be like progenitor cells and can transform in external retina and sometimes get some improve. But if the hole is not so big, I until 1,000 microns, I use internal limitant membrane. It's much easier and better because we can get much less problems with this surgery. But thank you.
Thank you very much, Dr. George. Thank you. We can move now to Dr. Noor. Noor, please.
Thank you. Thank you. It's my privilege to be here with you today. So thank you for the kind invitation. I share my screen now. Okay. So my case is with better, I think it will be. Okay. So it's a lamellar macular hole case. As its classification, it is described as tractional, degenerative, and mixed type. But recently, the tractional type has been determined as fovascisis with or without epiretinal membrane. But the degenerative type, which you can see in the below area, it is like there's a splitting in the neurosensory retina with some even enlarging the defect enlarging to the outer layers to the ellipsoid zone, and it can be sometimes combined. So in 2015, Peng and his co-workers have shown that there is a lamellar macular hole associated epiretinal proliferation in which these cases the diameter is larger and foveal base is thinner, and there's a disruption more frequently seen in the ellipsoid zone, and the visual acuity is prognosis is worse. So in histology, they have shown that this tissue contains this yellowish tissue contains macular pigments as well as Müller cells. So as you can see here, for example, we have to be careful about following up these patients and also maybe deciding when or which one to operate. For example, as you can see, there is a epiretinal LIHEP formation in the upper right. As you can see, there is not hyper-reflective as standard classical epiretinal membranes, and it's not tractional actually like the epiretinal membranes. And there you can see like the zones of degenerative holes going deep down or to the enlarging holes. So when to do the surgery? So we can discuss with my colleagues here. Usually we follow up these patients, and we follow up these patients for the OCT changes, the degenerative type I'm talking about, and if there's a decrease in the foveal thickness in the central area, increased diameter of the hole, or disruption in the ellipsoid zone on the outer layers, and also if there is any complaint of visual decrease of the patient. If not, we just follow up those eyes, or any metamorphopsia, monocular diplopia, for example, can be really very disturbing. So if there's a progression in anatomical changes combined with the visual functional changes, so we may go for the vitrectomy. And for the vitrectomy, as in the classical fovascisis, we peel the ERM and LM, but it has been shown that lately, if we, in the LIHEP eyes, degenerative or combined types, if we peel out those layers of LIHEP tissue and ILM peeling, the functional results are less. So Takahashi et al. Described like gentle manipulation of this tissue and embedding this tissue into the hole. And later on, Firistina described the double flap inverting technique with this LIHEP tissue inverted, and then ILM flap is inverted on top and leaving this tissue instead of peeling them all. We can get better results. So there's a case very short one. As you can see, it is yellowish. One tip is when you stain with the brilliant blue or the dual blue kind of double dye, it doesn't stain as it stains the ERM or the ILM. So and it makes a contrast of this yellowish Leheb tissue all around the hole or some area, with the contrast to the peeled, dyed, stained area of the ILM, for example. So you can describe, and first we have to search for it, of course. If we are not aware of searching for this tissue, we cannot find. It doesn't stain. So as you can see here, this is kind of yellowish, and it doesn't stain well like the rest of the membrane. So we peel gently 360 degrees and put it on top of the macular hole area, as you can see. Not peel it, maybe a bit trim it with the cutter if it is too thick and too large, and then peel the ILM. That's another case that I peel in many areas that just layered up all together on top of this yellowish tissue. But later on, I do it, for example, one ILM flap on top of this tissue, and from temporal and then to nasal on top of the other ILM flap. So this is the result. As you can see, I followed this patient like 3 years, but at the end, visual acuity, there was a decrease to 20/63. And then, as you can see, there's a bit enlarging to the outer zone. And after the surgery, it's a recent photo in the eye. You can see that the outer nuclear layer is more fully formed and the visual acuity increased. That's another case. As you can see, for different sections. And this patient, this gentleman, was an engineer, very clever person. He has the visual complaint of metamorphopsia and also monocular diplopia since 4 years, searching for a lot of doctors. And the visual acuity was 20/50 partially. So what I did was, I said, like I said, the Leheb tissue delaminated and the ILM flap bent over and face down with the gas SF6. And this is the 1 month OCT picture, but the visual acuity increased 20/25, starting from as long as the gas has passed away the macular area. There was a really fantastic, nice outcome of the layers in the retinal layer, as you can see here. And I still see him that the vision is, and the metamorphopsia decrease, he's happy. So we can discuss about these techniques, maybe what I'd like to learn what my colleagues do, recommend the surgery, and which technique they use in these lamellar macular holes. But there are some prognostic factors, as I can see, as we can see here. If there is a larger hole, it is a bad sign, or is disruption in the outer layers. Again, it's a prognostic, but bad prognostic factor. So as a conclusion, for the degenerative type, techniques with protecting the Leheb tissue and the ILM flap, visual rehabilitation is better, and with lower potential complications like we see in these cases, like full thickness macular hole development. Thank you for your nice invitation. So this is my case. I stop sharing. Any comments, please?
Sorry, thank you, Noor, for this presentation and excellent presentation. Okay, I think Dr. Amr, he want to start. Okay, please.
Really very nice case and very nice approach for the lamellar hole. I have to emphasize that we don't have to approach the patient unless he is complaining, because some of these patients live long time like this without any complaint, without any metamorphopsia. And the vision is good vision, actually. As you did, you have to follow up the patient until he is complaining of something like this, and then you can go for surgery. As well to know as well that there is a membrane really, which is cannot stain with the membrane blue. This is very important to know before going for this surgery, and not to peel it totally, just to, as you did, to put it in the a very nice case, and thank you for sharing.
Any other comment?
Yeah. Noor, very nice case. Thanks so much to share with us. I did learn something with you. The lap tissue is very friable. When you touch with the forceps, it's very hard to remove. And I'm seeing that I'm trying sometimes to remove with the forceps. It's not easy. And I see that you are removing the limitant membrane, and you just cover the hole with together, the lap and the limitant membrane all together. And your result is marvelous. I have some case that did not close the hole, and very skeptical to indicate surgery. But I'm trying next time your technique that's it's like a flower that you are removing 360 and just cover the hole with everything. Sometimes I try the flex loop to remove the tissue. It's more easy than a forceps. When you are using the loop, you can just scrap over the tissue. It's sometimes you can remove, but with forceps is almost impossible. But thank you so much.
Dr. Ahmed, please.
Yes, Noor, this is a fantastic case, really beautiful, and the two cases are beautiful. I do things a bit differently with the macular macular hole, as Amr said, and you mentioned as well. I don't operate on these patients until it's progressively getting worse. That's number one. Number two, I tell them differently. I tell them that the results are not robust as compared to full thickness macular hole, and we're aiming for stabilization rather than improvement of vision. And then if they get improvement of vision, it's a bit of a bonus. Number three, I just do a minimum surgery with them. So what I do is I do like what you've done, but I don't touch the ILM. And usually I don't peel the ILM in anything except macular hole. So I would always leave the ILM. And that's what I tend to do in these patients in very short, especially the degenerative type. I'm very cautious not to do anything with the ILM, especially the degenerative type. And even the standard ERM, with or without lamellar macular hole, I would only peel the ILM if it just comes with me because it's attached to the ERM. Otherwise, I just stain and see it there and leave it alone. So that's how I do it. But this is fantastic. The results is amazing.
Dr. Charat, you have anything to add?
Very nice surgery, Dr. Noor. Even I would have done in symptomatic patients, I usually do the ILM peel and tuck into the LHEP membrane. Only thing is, if the initial with the forceps is not coming, I would have used the finish loop to lift the edge of the membrane so that afterwards I can put it and peel it inside the LHEP. Very nice case.
Thank you. Thank you, George. You're right. It's sticky. So it is even difficult to peel it rather than put it back. It's easier. I think it's logical because it contains some macular pigment, some tissue, some Miller cells has already been shown. ILM peel, maybe Ahmed, it may not be necessary if you just fill with those tissue, the hole, and then put some, I don't know, maybe air exchange or something. It can work also. But as I see, for example, it is, yes, nice to emphasize that we don't recommend surgery right away to those eyes, which I just also follow up like maybe every 6 months, and then in some years they just remain the same. So if no problem, no surgery. But those are the cases who were symptomatic. I think this is the one thing that the patient should ask for. Some plus not be recommended. Let's have a surgery. And what else? And with the new OCTs, Ahmed, that's what I realized is we can really describe the smallest details, fine details much more, well. So we can pick, maybe as experience is increasing, who to suggest the surgery if he is symptomatic, of course. And I realized that if we do preserve this tissue, the vision is increasing postoperative, almost, of course, not in all cases, but I think minimalist surgery, protecting those tissues instead of peeling them all, can help for the better results. Thank you. I think
thank you very much, Dr. Noor, for this excellent and for all the discussions. So we can go to our last but not the least, Dr. Charat. please.
Dr. Muhammad, can I just mention something very quickly for completion?
Yes.
Again, for young people listening, there's 10% chance of full thickness macular hole with the lamellar macular hole surgery in the degenerative type. Something just to be aware of, like 10% may get full thickness macular hole. And also a number as well that I like numbers. 10% of lamellar macular hole may go into full thickness macular hole. So it's only 10% as well. So just good numbers to remember.
Okay. Dr. Shurat, please.
Thank Dr. Amri and Miyam for giving this opportunity. Hope my slides are visible.
Yes,
After
you can.
very nice, interesting surgical cases, I'm just showing you one medical cases, which is a medical and uvea cases. So my patient is a 41-year-old who was a coolie by accommodation, and he came with a right eye sudden diminution of vision since 4 days. His vision in the right eye was hand movements, and the left eye was 618, which is equivalent to 2040, 2060. Otherwise, in the anterior segment, it was normal, with left eye is having amblyopia because of esotropia. And the right eye, the anterior segment, occasional cells were there, and in the posterior segment, RL cells were there. When I saw the right eye fundus, we can able to see a presence of disc edema. There was multiple yellowish outer retinal whitish lesions, and we can able to see a motile worm in the macula, which is a very longer one, which is in the subretinal space. Along with that, there is a presence of subretinal fluid and the macular edema. So when this is a clinical video where you can able to see the mobile worm, which is moving very fastly in the foveal area, and I captured a OCT also where you can able to see the subretinal space, which is moving very fast. So this is our latest Hindi movie, which is showing. So I try to capture OCT angio also, where you can able to see, because of the so much of motile and so much of fast moving worm, I can able to get it the worm which can be captured in the OCT angio, and it is usually in the subretinal space. So based on these findings, I diagnosed it as diffuse unilateral subacute neuroretinitis. I wanted to discuss with the panel what is the plan of action when you see this type of cases.
Okay, great. So this is something different. So
That's a
okay,
beautiful case, really.
we want to go to George because the opposite side, India and Brazil, you can see. So George, what you will do?
Oh, Sharat, it's beautiful case, beautiful, beautiful. In Brazil, we have some of those, most in the north part, but we have some in the south, and we have different worms for this disease. And it's kind of ancylostomys, but it's not canis. And in Brazil, we have many different approach. Sometimes if you have a large one that you can see and you can try laser, but it's not easy to find. Sometimes you spend hours because the size of the worm is not the same. Sometimes it's very small, sometimes it's big, and sometimes it's move very fast, sometimes not. And then I have some colleagues in the north that spend hours looking for this, and they are hunting bugs and just find and laser, and the patient is cured. The other way to treat is use albendazole. We can have some paper that's published from Brazil that respond well. We have to use 30 days, twice a day, 400 milligrams for albendazole. And the more than 80% of the patients get better only with albendazole. But let's see what you did.
Any other comments from other colleagues?
Yeah, I managed only one case when I was a fellow in at Morphils, and a patient came from India, and the worm was like more peripheral, so we did laser and killed her, or killed him, I don't know. And then we did albendazole and steroids, and the patient did well. But this one is in the macula. Again, it's so interesting. It's a beautiful slide, beautiful case. Be interesting to see what you've done.
Noor or Amr, any other comment before Sharat continue?
Actually, myself, I didn't have a case like this, but there are some sporadic cases also from Turkey. So yeah, laser always said, I think. So I'm curious what Sharat has done.
Okay.
So
Amr?
Yeah, just please continue. I actually Here
We
in
want
our
to know what
area,
you
we
have
don't
done.
have cases like this. So yeah, I know it has to be lasered if you can, and sometimes you need to do surgery. But actually, I didn't experience a case like this before. It's not. It's rare here.
So, thank you all. So, as you know, the duation is an infectious disease caused by nematodes, and it was previously initially described by Parson, and later Gas and colleagues named the word duation in 1978. In India and most of the countries, we see the largest, smallest worm is Belarus, the roundworm, and the smallest is hookworm, and the largest the roundworm, which we can able to see. And in the early stages, we will see a central or paracentral scotoma. There will be presence of vitritis, disc edema, or there can be recurrent crops of multifocal retinal lesions. And the late stage, they can go for optic atrophy. There can be a decreased visual acuity. There can be a crisscross pattern of subretinal bands. So in the acute case, as you can able to see in the upper picture, you may not be as they discussed, we may not able to see the worm. That time when we see this yellowish outer retinal crops, we try to do a laser on that area, and then we try to give a albendazole injection tablet. Yeah, similarly, in the chronic stage, you can able to see the presence of multiple subretinal tracts. There can be a foveal thinning and optic disc thinning. So coming to in the acute case, you can able to see a presence of macular edema, and in the late stage, you can able to see a foveal thinning. So as they told, we can try to do a direct laser to the worm directly, or along with that, we can give albendazole and steroids to decrease the inflammation. So coming to our case, I did the investigation to see what are the strength for the stool culture and all to look any worm I can able to get it or not. And because it was on the fovea, I put a light for 3 to 4 hours. I made the patient wait so that at least the worm goes extra foveally so that I can try to hit the laser, but it didn't move away for 3 to 4 hours. I tried to do a few laser, but because it is very close, because it is very motile, I was not able to do and hit the worm directly. I did few extra foveal laser. So once I did that extra foveal laser, I started him on albendazole and ivermectin stat and gave albendazole for 14 days. And along with that, I started oral steroids also. This is the one where with the motile worm, I'm trying to do a laser, but it is very mobile and I'm not able to hit it directly. So the next day follow-up when he came, you can able to see the worm was half paralyzed. Still the half was moving around. Sorry, I don't know that OCT is not showing up. And there was an increase in the macular edema. Maybe because the worm was very motile and it was moved so much, the inflammation worsened. And after the steroids and albendazole, this is a 1 week follow-up where you can able to see the worm has disintegrated and it is completely gone, and the visual acuity has improved to 20/80. This is a 3 weeks follow-up where there can some amount of extra fiber scarring has happened, but still the patient is maintaining the vision of 20/80. This is the initial visit and this is the last visit at 3 weeks. So this case shows an importance of multimodal imaging on the case of DUSN. Laser photocollection is very important to the visible worm if is ideal. If you are not able to visualize the worm and in the absence of vitritis, it's better to do a few laser to the outer yellowish outer retinal crops so that it will help to increase or it will facilitate the intraocular drug penetration by increasing the blood retinal barrier. And 1 dose of concomitant oral ivermectin also I prefer along with oral albendazole. And awareness to be given regarding the hygiene and maintenance is very important. Thank you. I thank for a patience hearing.
Thank you very much, Sharat, for this an excellent and extraordinary. I never hear about it actually. I don't know, maybe some of us didn't see it. Okay, is there any comment? But it is almost the same idea as all friends that what they have done, if they are either to laser it or just to give the medication that's to overcome. But did it, how it will die or what it will happen?
It will die there because we gave a albendazole. Usually, we try to do a laser in the periphery. If it is there, it will disintegrate. The most important thing is when it is if we try to hit a laser directly or if you're giving albendazole, along with that, giving steroids is very very important. When it is disintegrating, it induces lot of inflammation. If you won't give steroids, they will develop the capiretinal proliferation and other vitritis and all. So along with albendazole, I feel steroids is very, very important in these cases.
Okay, Noor, yes.
Very nice case, Sharat, because it is nice to put the diagnosis early and treat it as well as like this. Because I now remember that we had a case, even published as a case report, because it was presented in a child like an endophthalmitis kind of type, what we tried as retinal detachment and the granulomatous thing in near the macula, and we had to take it out and biopsy, and then we revealed that toxocara canis, all the organisms are dead, but the eye caused a lot of damage. So if it happens like that, the end case, I've seen the end case, so it was really with low vision. So it is nice to realize it in this stage, acute phase, I think. Thank you for sharing. It's such a lovely case.
Any other comment? George or Amr, Dr. Ahmed?
Sharaf, very nice case. One thing that you just teach us was using ivermectin together with albendazole. I never did that. I use one albendazole. Next time I'm gonna try. Just once pill. Not need to be like the albendazole that's 30 days. It's just one.
Yes, ivermectin is a static dose. So one dose of ivermectin is enough. But because along with the studies has shown that albendazole to be given for more than 30 days, I gave it for 2 weeks. Most of the times they say ivermectin one single dose is enough to kill the drug because it's in the fovea. I want to make it paralyzed as early as possible.
Very good. Thank you.
Okay. Dr. Ahmed or Dr. Amr?
Nothing really from my side. It's just a very beautiful case, and I think the ivermectin use is a great idea. I mean, I've only seen one case, but I know now what to do if I see another case.
Anyway, thank you very much for all our speakers. Thank you, Dr. Ahmed Salam, Dr. Amr, Dr. Fahad, Dr. Noor, George, and Sharat for this an excellent meeting. Thank you for the Roche for sponsoring this meeting, and thanks for the participants or attendees, they are with us. And also we want to announce that our meeting for conference next year in MIOM, it will be from 31st of October to 2nd of November. And also next year we are planning to do something new regarding the webinars. So from the next time we will announce, and who want to apply to present, he can present. We will have 2 sessions, I mean 2 or 3 parts. The first part will be for young ophthalmologists, anyone below 40 years of age. So we will select those they are applying. So we will get 3 of them to present for 30 minutes and discuss with expert. Then we will have 30 minutes for sponsoring company. Then we will have another 30 minutes for the experts to talk about the same, what the young ophthalmologist had present, and also to show the differences. And also it will be all the 3 of them who is going to be selected to present, they will be free registration to attend also the MIOM conference. And from all of them, we will select another 3 to present also in the MIOM conference in the next year. This is what I want to announce, and then I'd like to thank you all, and good night. See you all. Thank you very much. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.
Thank you so much. That was a great session.
Thank you.
Thank you. Happy New Year.
Thank you. Happy New Year for you, Noor. Thank you. See you.
Thank you for the invitation.
Thank you.